Apply now for the Morris Fishbein Fellowship in Medical Editing. This is a unique one-year fellowship offered by JAMA to introduce physicians to all facets of editing and publishing a major medical journal. The application deadline is January 5th, 2025. For more information, including how to apply, go to jamafishbeinfellowship.com.
From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Lisa Simon, who is an assistant professor at the Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Today, we will be discussing a JAMA research letter that Dr. Simon co-authored titled Availability of Dental Benefits Within Medicare Advantage Plans by Enrollment and County. This article was published online on December 26th. Welcome.
Thank you so much for having me. I'm very happy to be here today.
So as background, what percent of total U.S. Medicare population is enrolled in Medicare Advantage, and how has enrollment changed in the past decade?
As of now, more than half of all Medicare beneficiaries are choosing to enroll in a Medicare Advantage plan. And that number of people has really exploded over the last 15 to 20 years. Starting in 2007, there were only about 15 to 20% of Medicare enrollees enrolled in Medicare Advantage. And now, again, that number is above 50% and rising every year.
And traditional Medicare does not cover most dental care, but Medicare Advantage plans may offer dental coverage as a supplemental benefit. Can you describe what previous studies have shown about dental utilization and out-of-pocket costs among both Medicare Advantage and traditional Medicare beneficiaries?
So because of a limitation that's built into the Social Security Act of 1965, traditional Medicare cannot provide standard dental coverage as part of its benefits package. On the flip side, Medicare Advantage heavily advertises dental services as one of the appealing supplemental benefits that it's able to offer that a traditional Medicare program can't. In fact, up to 85% of daytime TV ads for open enrollment in Medicare Advantage touted a dental program. So it's clearly something that's compelling to potential enrollees. Despite the fact that Medicare Advantage, again, heavily advertises its dental benefit and traditional Medicare doesn't have one, there actually aren't very large differences in the number of people in each group who are actually able to see a dentist every year. So only about half of Medicare beneficiaries in either Medicare Advantage or traditional Medicare are able to get to a dentist every year. And when they do, the vast majority of their expense is out of pocket. In fact, for people who visited a dentist, it's over $1,000 a year.
So the goal of your research letter was to describe the benefit characteristics of Medicare Advantage plans and to determine the number of beneficiaries enrolled in plans with comprehensive dental benefits. Why is this an important question, and why did you pursue this research topic at this time?
We know that Medicare Advantage plans like to say that they offer a dental benefit and like to advertise that they offer one. But the nature of what that dental benefit is really important when we know that Medicare Advantage beneficiaries aren't seeing a dentist any more than their peers in traditional Medicare. So we use publicly available data to analyze the potential quality of these Medicare Advantage plans and understand where that discrepancy could come from.
And so moving on to the methods used in your study, can you describe your data sources?
So we use publicly available data that the Centers for Medicare and Medicaid Services places online on a quarterly basis, which is known as the Plan Benefits Package files. This actually covers an enormous amount of data about Medicare Advantage supplemental benefits, not just dental care. But it requires each plan to submit a bid to the Centers for Medicare and Medicaid Services describing what benefits are covered within that specific plan. We were then able to look at those quality metrics and note what percentage of plans were actually able to meet a quality benchmark for their dental benefit that we determined using expert commentary in part from the American Dental Association and from the published literature.
So you developed a list of requirements for a comprehensive dental benefit that represents parity with employer-sponsored plans. I was hoping you could discuss the 10 characteristics of a comprehensive dental benefit that were presented in Table 1 of your research letter.
So one thing I want to emphasize is that we didn't try to hold these plans to a very high standard. As many listeners who perhaps have a dental benefit may know, dental insurance isn't really insurance in the traditional sense like Medicare insurance is. It isn't designed or built to offset a potentially devastating financial cost. Rather, it works almost like a coupon book, providing progressive discounts, most commonly on preventive services or lower cost annual services. So rather than meeting a benchmark of a high quality or idealized dental benefit plan, we tried to identify plans that at least met what I would consider the relatively low benchmark of a traditional employer-sponsored insurance plan. Some of the criteria that we designated were that preventive services, things like annual cleanings, would have to be covered without a copay or coinsurance, that those services would be available without prior authorization approval from the plan, and that at least 2 dental cleanings per year were covered, and that there was no referral from, for example, a primary care physician for those services. Then we required that at least some non-preventive care, things like fillings, dentures, root canals, or anything else, would have to be offered and include a comprehensive scope of services, so not just one of those things. We set a maximum for the annual benefit of at least $1,500. That mean coinsurance needed to be no more than 30% for this range of services, and that there would be no additional premium annually for any of those services, meaning people didn't have to pay more money to participate in the plan at all.
And in terms of the main findings of your study, what percentage of Medicare Advantage beneficiaries were enrolled in a plan that offered a dental benefit, and what percentage were in a plan that provided a comprehensive dental benefit?
So looking at our sample from the end of quarter 4 in 2023, there was a total enrollment, excluding those participants who were in a plan and not living in the community, of 27,222,481 people. Of those beneficiaries, 94% were in fact in a Medicare Advantage plan that offered a dental benefit. But when we started using our quality criteria to narrow that down, we found that only 4.1% of those beneficiaries were actually in a plan that met our quality standards and were in a plan with a comprehensive dental benefit.
And among these Medicare Advantage plans, what were the most commonly offered dental services?
Several things were quite commonly available. The most common thing was that preventive services were indeed covered, that there was coverage for at least 2 dental cleanings a year, and that some version of non-preventive dental services were offered.
And what were the least commonly offered dental services?
The least commonly offered dental services were a lack of copay or coinsurance for those preventive services, that a mean coinsurance was less than 30% or equal to 30%, and that there was no additional premium to be enrolled in the plan itself.
Were there any results in the study that were surprising to you?
Well, I have to say that we went in with a certain hypothesis, which was that we would find that plans probably didn't meet quality criteria as we were hoping, given our previous work had shown that patients can't really access care as part of these plans. But I do think that the overall drop-off is actually quite surprising. It is highly cited that there are such a large, overwhelming majority of MA plans that offer a dental benefit. It exceeds 98% currently. But when you winnow down using criteria that we intentionally made rather conservative, the fact that it shrinks down to being only 8.4% of plans actually meeting these criteria is extremely surprising. I think it was even smaller than I expected.
Can you outline a few limitations of your study?
Probably the biggest limitation in our study is that there isn't consensus on what a comprehensive dental plan might actually include. Like I mentioned before, dental plans often function more like coupon books than they do like insurance. And so there's no set of standards for what a great dental plan might look like. And while we used the best expert feedback we could, the things we picked might not align with what other people might pick. And I think a lot more work needs to be done in this area to identify the quality standards in a dental benefit that actually lead to people getting better care. Some of the other limitations we have are that while we used the presence or absence of a premium annually as one of our criteria, we don't know what that premium could be. It could be $1 in some plans and $1,000 in others, and we simply didn't include it in our analysis. The last thing I'll mention is that one major barrier to access to care is whether the network of dentists participating in a plan is adequate. While we were looking at the benefits that are covered or not covered by a dental plan, we can't speak to whether there are enough dentists in a particular region or county to make those benefits usable at all.
Do you have any future research planned on this topic?
We do. The next work that we're focusing on is evaluating whether these quality metrics actually equate with utilization and oral health outcomes among Medicare beneficiaries using a combination of this publicly available data and the Medicare Current Beneficiary Survey, which is a large national survey of Medicare beneficiaries. We're also looking at some of the county-level characteristics that are associated with having access to a number of high-quality dental plans. For example, whether wealthier counties or higher population counties might be more likely to have access to some of these plans.
Before closing, is there anything else that you'd like to mention that we haven't previously discussed?
I'm just thrilled that JAMA is drawing attention to the importance of oral health, particularly as it relates to aging and policy. So I'm really thrilled and grateful that that's a conversation I get to be a part of. Thank you.
Thank you so much for sharing your thoughts with us about this interesting topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. Lisa Simon. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.